Are we really using psychology terms the way that they're meant to be used? And what does it actually mean when we say words like anxiety, trauma, or OCD? Is it possible that perhaps we've been using psychology terms incorrectly without realizing it? Welcome to Psychology Reconsidered. My name is Rihanna, and I'm the host of this podcast. Just as a disclaimer before we get into today's episode, this podcast is designed to make psychological science and reputable mental health information more accessible. However, the information shared is for educational purposes only and is not intended to provide therapy, diagnosis, or individualized medical or psychological advice. So without further ado, let's get into today's episode. So today we will be discussing why it is the case that so many psychological terms become misunderstood once they enter everyday conversation. It is more often than not that the misuse of these terms, if not all the time, does not come with the intention to cause any harm or take away from the severity of these experiences, symptoms, and conditions, but rather more often it is due to the lack of knowledge or lack of understanding of what these terms really mean. And so essentially hearing others misuse the terms in conversation often just results in this perpetuation of using these terms in very specific context, scenarios, and situations. And so what might be helpful today is for us to really dive into some of these terms to perhaps shed a little bit more awareness, knowledge, and understanding regarding where these terms actually come from, and perhaps with time, develop a greater appreciation and awareness of the importance of these terms and phrases, and so on and so forth. So the first one that we'll get started with is understanding what OCD really means. So when we say OCD, we mean obsessive-compulsive disorder. And many of us have probably heard or ourselves used statements such as, I'm so OCD, or you're so OCD with your cleaning, or you're so OCD with washing your hands and keeping everything clean. And once again, although it doesn't come from an ill intent to misuse this term, there are differences in terms of the general population's understanding of what it means to say that one is so OCD or that we ourselves are OCD versus what it means in the clinical context. So just to shed a little bit of understanding onto this misconception, the first thing to keep in mind is that OCD is not a personality trait per se. It's not an adjective, and it doesn't actually encompass as much control on the behalf of the individual as we often think. So it's not this transient approach to responding to one's environment as we might often think. Rather, the true definition comes from our clinical understanding of what obsessive-compulsive disorder really is. So the first thing to understand here is that OCD is in fact a mental health disorder that is found under the category of obsessive-compulsive and related disorders in the DSM. And the DSM stands for Diagnostic and Statistical Manual, which can be viewed almost like a Bible the psychologists use to assess for and diagnose mental health disorders. And so according to the DSM, OCD involves the presence of something we call obsessions, compulsions, or both. Now, just to get a little bit of an appreciation and understanding about what these terms mean, when we say obsessions, these are recurrent, persistent thoughts, urges, or images that are experienced that individuals find to be disturbing, intrusive, and unwanted, and that most individuals experience a lot of anxiety and distress associated with these recurrent and persisting thoughts. In addition to that criteria, the individual tries really, really hard to try to either ignore or suppress these thoughts, urges, or images, or to neutralize them in some way through some sort of action. So that is the definition of obsessions, is these repetitive, recurrent, persistent thoughts that the individual does not necessarily want them to be there, and they will do things mentally to try to reduce their distress. Now, associated with it, in addition to these obsessions, individuals with OCD will more often than not also engage in what we call compulsions. So compulsions are these repetitive behaviors the individual feels compelled to do in response to that obsession, or according to some sort of rules that they feel like they must be following or they must apply very rigidly. And the purpose of these behaviors or these compulsions that the individual engages in are aimed at preventing or reducing the distress or the anxiety that is in the picture, or from preventing something bad from happening, like a dreaded situation or a dreaded event. And simply having those obsessions and compulsions wouldn't necessarily be sufficient for diagnosing someone with obsessive compulsive disorder. There are a few other criteria that need to be met. There's one other important criteria that needs to be met, and it is the fact that these obsessions and or these compulsions are extremely time consuming, or they cause significant distress or impairment in one's life. So whether that's in their social life, in their occupational life, or in other areas of life that the individual deems to be important to them. And so it's insufficient to diagnose someone with obsessive compulsive disorder simply through the presence of having these intrusive thoughts or these compulsive like behaviors. These thoughts and these behaviors should be taking up a significant chunk of their day every day, or be experiencing that really high distress associated with the obsessions and or the compulsions. Now, related to this, something that is important to note is that these obsessions and compulsions that individuals have are often thematically related. So, for example, thoughts of contamination are often associated with the compulsion, such as washing hands excessively, or perhaps a thought of harm or thoughts of harm are related to repeatedly checking something to prevent something bad from happening in the context of harming oneself or others. Now, a key thing to note here as well is that the compulsions that are conducted by the individual to reduce the distress or that feared outcome are often either extremely excessive or it is not connected in a real way. So, for instance, if an individual feels the need to arrange their pillows in a specific way in their bedroom to prevent something bad from happening to themselves or their loved ones, that link between that action and that feared outcome is not connected in a realistic way. So there's either that piece of it being extremely excessive or out of the norm, or that connection between the feared outcome and the behavior is often not connected in a real way. So just to bring this back to those statements that we may often use unintentionally, such as I'm so OCD or you're so OCD with your cleaning, the key thing here is that the individuals don't choose to have these intrusive thoughts or experiences or engage in these obsessive-like and compulsive-like behaviors. And so there's that limited control that sometimes we may not realize when we are using phrases like this to describe ourselves or the behaviors of others around us. Another note is that it's not situational. Usually, it is persistent. It is occurring on a daily basis. It is occurring in very specific contexts, and it's hard to control those thoughts and those compulsions in those contexts. And so there's that very limited control over the thoughts and the need to want to neutralize those thoughts by another thought or action. And sometimes individuals even lack that insight into the fact that these obsessions that they're having or these compulsions that they're having are indeed problematic, or that they even have this pattern of obsessions and compulsions. And so just to wrap everything up, when we refer to obsessive compulsive disorder, it is a clinical diagnosis. It is quite persistent, uncontrollable, and intrusive in nature. And unfortunately, individuals that are diagnosed with this mental health disorder have very, very limited control in terms of when these thoughts come up, how often they come up, and what they do in response to these thoughts. Unlike what we might think when we say someone is acting in an OCD-like manner. Now, shifting gears here a little bit to our second misconception of our episode. This one is related to trauma and traumatic like experiences. So, for example, once again, a very unintentional, unharmful thing that we might say is, this gives me PTSD, or watching this movie gives me traumatic flashbacks, or oh my goodness, that event was so traumatic. Now, let's try to understand the misconception here. So similarly to OCD, or obsessive-compulsive disorder, labeling someone or an experience as PTSD is inaccurate because PTSD is actually not a descriptor of a transient experience. It's also not a state that one enters temporarily, and it actually encompasses many more layers than just experiencing something traumatic. Like OCD, PTSD is also a clinical diagnosis, which is post-traumatic stress disorder, and it's found under the trauma and stressor and related disorders in the DSM. It has 4 criteria that individuals need to meet in addition to the presence of a traumatic experience. And the way that the traumatic experience is defined is having exposure to actual or threatened death, serious injury, or sexual violence, whether it's you experiencing the traumatic experience directly or witnessing in person the event as it occurred to others, or even learning that some sort of traumatic experience occurred to someone close to you. And so if one of those criteria are met, there are further additional criteria that need to be met in order to determine whether someone actually meets for PTSD. So the additional criteria includes having some sort of intrusive symptoms. So that can be in the form of recurring memories, recurring dreams, and these are often considered involuntary and distressing by the individual. The other piece here is a persistent avoidance of things that remind the individual of the traumatic event. So a large part of post-traumatic stress disorder, or any traumatic disorder, involves that avoidance of individuals, conversations, smells, sights that remind the individual of the trauma. The third piece here is some sort of alteration in cognition or an affect that the individual experiences. And usually these alterations are negative in nature. So it can include things like having negative beliefs about yourself or other people or the world, experiencing some sort of distorted cognitions about the cause of the traumatic experience or the consequences, having a reduced or completely diminished interest in participating in things that used to bring you joy. And so there is that change in how one was prior to the event versus how they are now after this traumatic experience. And lastly, there is that change in arousal and reactivity that the general public tends to be a little bit more aware of. So that startle reflex might be heightened. There might be more hypervigilance in different environments, problems with concentration even. And so when someone has a traumatic experience, in addition to having that traumatic experience, there has to be these cluster of symptoms that are placed together to consider someone to be meeting clinical threshold for PTSD. So putting it together, it's not simply about experiencing something that is unpleasant and having those subsequent aversive reactions to it. Rather, there's much more to it. In fact, there is research to suggest that the way that we store traumatic memories versus non-traumatic memories in our brains is in fact different. So it's not simply about experiencing some sort of traumatic event. It's about how our brain processes that traumatic event, and the fact that it has very unique neuronal wirings when we compare it to non-traumatic experiences and memories. And so it appears that traumatic experiences and memories of these traumatic experiences are stored in our brain in a splintered fashion. And there's a reason for that, and it almost acts as a protection from re-experiencing the event again. So many individuals might experience partial amnesia about the details of their trauma or have what we call emotional numbing when reminded of the event. And that is there evolutionarily to, in a way, protect ourselves from re-experiencing the same traumatic experience. And the reason why I'm bringing this up is because it's important to understand that exposure to something that is aversive, unpleasant, and that might cause a little bit of that arousal isn't sufficient to classify it as having a traumatic flashback or this giving me PTSD. There's a lot more that is encompassed in this definition, and just something to be aware of. And so many will colloquially use the phrase, I have PTSD from XY experience. And though that might be the case for some individuals, I think having a little bit of a number, a quantitative perspective and a little bit of a number to understand how common PTSD might put things into perspective. So when we look at the lifetime prevalence of post-traumatic stress disorder in North America, and we're referring to the United States specifically, it is actually just under 7%. Now, a key note here that might be intuitive to us is the fact that this prevalence actually increases in individuals that work in places that may increase the chances of exposure to traumatic experiences. So for instance, police officers, firefighters, and military personnel. So though in the general population, it's hovering just under 7%, in individuals that have an increased chance of seeing things that may be perceived as traumatic, that percent drastically increases. So hopefully that clarifies things a little bit in terms of what is defined to be a traumatic event and how clinically we may define an event to be traumatic, as well as what the symptom clusters might look like for someone who is clinically meeting diagnostic criteria for PTSD. Now, moving on here to our third misconception. This one is around panic attacks. So very often we may say things like, this experience is giving me a panic attack, or I am panicking, or I'm going to panic all day when I go to the store with all these people there. And rightfully so, this makes sense in our mind because the way that we may interpret a panic attack is something that really increases our anxiety and something that is unpleasant, something that we feel both in our mind and in our body. However, there's a very important distinction here in terms of experiencing unpleasantry in the context of heightened anxiety, heightened worry, versus what is truly defined to be a panic attack. Where the difference is derived from here has to do with the difference in severity between something that makes you nervous, uncomfortable, worried, versus actually experiencing a clinical level of a panic attack. Now, the reason why panic attacks are different from what we just spoke about in terms of OCD and PTSD is that panic attacks are not formal diagnoses. Rather, they are what we call specifiers that are added to different clinical mental health diagnoses and mental health disorders. And so just to unpack that a little bit, it is not a formal clinical diagnosis, but it is an experience that is often included within anxiety disorders and mood disorders, in addition to a variety of other disorders. Now, the way that we clinically define what panic attacks are, they are abrupt surge of intense fear or intense discomfort that reaches within minutes of starting. And usually it's somewhere under the 10-minute mark. They can be expected or unexpected, meaning that something triggers them, or sometimes they come on without a known cue or without a known explanation. And where it gets a little bit more complicated is that if the unexpected panic attacks become recurrent, they cause a lot of distress, they cause avoidance or a change in behavior in an individual and in their life, it can develop into something we call a panic disorder. Now, this would be a clinical disorder just like OCD and just like PTSD. And so, in addition to experiencing perhaps pounding of the heart or palpitations, sweating, the shaking feeling of choking or that chest pain or discomfort, perhaps nausea, there has to be that concern of having another panic attack or making changes in an individual's life in order to avoid having another panic attack. So when we talk about panic disorder, in addition to all those physiological experiences that an individual has, there's this fear of a future panic attack or this change in lifestyle, such as avoiding exercising or avoiding going to certain places or needing to bring someone with you everywhere in anticipation of having a panic attack. When there's that combination of the physiological symptoms with that avoidance or with that fear of developing another panic attack, that's when we would classify this to be panic disorder. And of course, more often than not, individuals will experience that distress. They will experience that impact in their day-to-day living, whether it's at work, at school, in their personal lives. And so putting all of that together, that's when we would consider the diagnosis of panic disorder. And so the intensity of experience is often much greater than what is experienced by most when they say, I've been panicking all day. In fact, panic-like symptoms are so intense for some people that they will indeed think sometimes that they are going crazy or that they are losing touch with reality. There may be this fear of dying. And in fact, a lot of individuals that have these chronic, reoccurring panic attacks might actually end up in the ER. So they are more likely, on average, than individuals who do not experience panic attacks to actually end up in the emergency room. And several clinical reports as well as studies have suggested this. One study, in fact, reported that the prevalence of panic disorder in patients with non-cardiac chest pain seen in the emergency setting is as high as 25%. So individuals that are showing up to the emergency room due to fears of some sort of cardiac chest pain and cardiac related concerns are actually individuals that are meeting criteria for panic disorder rather than some sort of physical ailment. Now, the unfortunate thing here is that a lot of individuals in the emergency rooms might not screen for that, and they may actually be discharged without a physician considering that panic disorder or a panic attack is in the picture, and they may instead label it to be something like non-specific chest pain. So there's a lot of obstacles in the medical healthcare system that individuals who on a recurring basis experience panic attacks, unfortunately, they get missed through the cracks because of other considerations and because of how intense their physical-like symptoms may be. Now, moving on to our second last concept of the episode, which is revolving around the idea of binging. So once again, we've all heard or ourselves have said things like, I'm going to binge eat this bag of chips or this chocolate bar, or I went on a binge this weekend and ate all the snacks I wanted. Once again, the misconception here lies in the fact that binging or binge eating is in fact a clinical term in the context of several eating disorders. And the one that we'll be untangling a little bit today is binge eating disorder. So when we talk about binge eating disorder, of course, it is classified to be an eating disorder, which involves recurring episodes of binge eating. Now, in order for something to be classified as binge eating, the eating has to occur in a discrete period of time. So it can't be kind of throughout the day. Usually it's confined within several hours. And usually the amount that is eaten is definitely larger than what most people would eat in a similar period of time under similar circumstances. Not only that, but the episode of binge eating involves this lack of sense of control over the eating during the episode. So almost feeling as if one cannot stop eating or control what or how much eating is done in that episode. Because it's classified to be a clinical diagnosis, these binge eating episodes do in fact cause a lot of distress for individuals. So they are often distressed by the fact that they have this lack of control. And this lack of control and these episodes are often occurring several times a week for several months at a time, or several years, depending if the individual seeks help or not. And so similarly to OCD, there is this emphasis on lack of self-control. And there is this recurring nature to the eating disorder. And there is this distress and impairment in daily functioning. So when we say things like, I'm going to binge eat tonight, that is inconsistent with the idea that binge eating does not involve that control. And it's not this one-off experience. In fact, it's this reoccurring experience that individuals tend to not want to have. And it's not about, I'm so hungry, I'm going to eat 1.5 the amount I usually do. Rather, the eating can actually occur when the individual is not physically hungry, to the point of getting sick, and to the point that there is often shame involved in the picture as well. And so once again, the frequency, the control, the severity is what distinguishes the general population's understanding of what binging or binge eating is versus the clinical conceptualization of this mental health disorder. So a fifth concept that I just want to quickly touch upon and unpack a little bit as well is our understanding of anxiety in our society. And generally, the fact that we conceptualize anxiety as something bad, right? So I just want to talk a little bit about what anxiety really is, why it's not always bad, and why we actually do need it in fact. So the first point that I want to make here is that there's often a blurry line when we talk about feelings like worrying, anxiety, having an anxiety or panic attack, versus experiencing a clinical level of anxiety. So those lines often get very blurred. And something to keep in mind is that worry is in fact a normal part of everyday life. So you might worry about an exam before an exam. You might worry about a job interview before the job interview, or while waiting for an important piece of news to be shared with you. Similarly, feeling anxious is a completely normal experience, and it's a completely normal emotional response to situations when we perceive them to be uncertain, challenging, or threatening. And so putting all this together, I just wanted to shed a little bit of light onto the fact that anxiety is in fact adaptive. So a lot of the time, especially in today's day and age, when we hear the word anxiety, anxious, we label it to be maladaptive at all times. And though it can be maladaptive under certain criteria, which we will talk about in just a moment, having a manageable level of anxiety is adaptive, in fact. And in fact, we can never fully get rid of it because our evolutionary buildup made us this way for a specific reason. It prepares us to pay attention, to solve problems, and to respond to potential danger. Now, some level of anxiety is adaptive and normal. And in fact, like I mentioned, we can never fully abolish all the feelings of worry and all the feelings of anxiety. However, it does become maladaptive when the anxiety is hyperactive. So for instance, when we are reacting to stimuli in our environment to an extended amount, meaning that we are responding to danger when there is no real danger in our environment. So when our fight or flight system is overactive, it's taking up a significant amount of our time, it's causing impact. That's when we would consider something to be a maladaptive amount of anxiety. So when we think about anxiety disorders, and again, there are a variety of different ones, which for the purposes of today's episode, we're not going to get into, but an anxiety disorder does not involve simply experiencing anxiety. It involves anxiety that is excessive, that is persistent, that is difficult to control, and it is significant enough to cause interference in a person's daily life, their relationships, their work, or their overall functioning. And so what we want to think about in the context of anxiety is that it's not always bad. However, when the intensity is heightened, when the duration is heightened, and the negative impact on one's life is heightened, that might indicate to us that it's not simply the presence of anxiety, but rather it's that hyperactivity of our anxiety response. And so we want to be careful when we are teasing those apart, as a little bit of anxiety is productive. However, unfortunately, in today's world, in today's day and age, we tend to be a little bit more hypervigilant. So that wraps up our third episode, and I wanted to thank you all for listening to Psychology Reconsidered. I hope today's episode gave you something new to think about, a practical insight to take away with you, or perhaps a belief worth reconsidering. Until next time, stay curious, keep asking thoughtful questions, and don't be afraid to reconsider what you think you know.